Good afternoon, everybody, and thanks again for joining me for another conversation about the science behind the COVID-19 pandemic. I'm Jayatri, Chief Bioscientist at the Franklin Institute, and I'll be joined shortly by Dr. Frances Jensen, the professor and chair of neurology at the University of Pennsylvania. She's also the author of The Teenage Brain, and so today we're going to be talking about all things COVID-19 and the brain. So one of the things that inspired this particular topic of conversation is that we've talked a lot about how COVID affects the lungs, how it affects the immune system. But a recent study came out in which a hospital in Wuhan in China reported that up to a third of patients that they were seeing were also experiencing some neurological symptoms. And so we're curious about how this disease is affecting the brain as well as some of these other systems in our body. And then of course, there are the mental health impacts of it as well. And I see that Frances has joined us. Hello, Frances, how are you?
Hi, everybody, how are you?
I was just introducing some of the context around our discussion that, as we've been talking about the impact to other systems in our body of this disease, one system that's just starting to get more attention is how this disease affects the brain. So we wanted to talk to you today with your expertise in this area and start talking first about what some of the neurological symptoms of COVID are. And I wanted to start with one that I think has gotten a lot of people's attention, both from personal experience, but also one that I think kind of catches people's curiosity, which is the loss of smell and taste. What do we know about this so far?
Yeah, it's a really interesting area because it kind of started to creep up and was ignored with the first wave of, although it was happening in China, and gradually started to work its way into the literature. And I think as of about 6 weeks ago, it was more known that anosmia, meaning lack of smell, and ageusia, meaning lack of taste, were actually fairly prominent symptoms for people with, it can be for, and can actually be in somebody who has no other symptoms. So it's curious, why would this be? So as you know, when we smell or taste, some of our taste is really just the aroma of the food coming up into your nose, which in the back of your sinuses, you have something called an olfactory epithelium. So that means olfaction is smell, and epithelium means sort of coating, layer of cells. And these layers of cells have receptors for different odors. There's thousands of odors. Humans actually don't have an impressive number of varieties of these things, but if you go to a dog, it's like 1,000 times the number humans have. For instance, they have this wealth of olfactory receptors in their in the back of their sinuses that when they breathe up. And of course, anybody who's walked a dog knows that they live through their nose. In fact, humans are very visual. I would say a lot of animals are very driven by sense, their sense of smell rather than anything else. And, they're revealing the world through what they're smelling on a base of a lamppost or on a grassy verge. And that's all coming in through the olfactory epithelium. So each smell molecule hits a different receptor, and that goes up into the brain through something we call the olfactory bulb and directly goes into the smell sensors of our brain.
And that's actually a little bit different from some of our other senses. That smell
is different, that it's such a direct route. Right. It's not going through much of a way station that some of our other senses go through. Our other senses come in, they go to like a processing area called the thalamus, for anybody who's interested, and then get sort of packaged off to, if it's a visual, stimulus, it'll get packaged to visual cortex. If it's a sensory stimulus, touch, it'll get packaged off into the proper region of your sensory cortex for whatever body part it was. But interestingly, olfaction goes straight in. And the interesting thing about that is that it's one of the oldest senses we have, and one of the oldest senses in teleologically across all of the different spectra of animals. I mean, worms have smell. They don't even have eyes, but they
so
have
looking
smell.
across the
So
evolutionary spectrum.
evolutionary, it's the oldest. And it's very interesting because it found a direct route into the brain rather than through the more sophisticated processing centers of higher order animals. And what's really interesting, and I know this is a bit of a digression, but it'll all make sense as to what I'm saying, is one of the, you realize that some of your best memories are smell memories. I bet everybody listening could say that they remember the smell of their grandmother's house, or the smell of their grandmother, or the cookie that she made, or the apple pie. You remember it forever. It never goes. Whereas other memories come, go, you got to rehearse them again. And this is because it goes directly into your memory center, right from the outside, and with basically only one stop back into your brain. Whereas other memories that we have to create, like visual or even hearing, have to go through this way station, then get processed. And there's some leakiness, if you will.
Right.
And so anyway, so there's a direct effect entry. This is one of the fascinating things about COVID, because COVID, the SARS-CoV-2 virus, actually is seeking a receptor called the ACE2 receptor that you may have heard about, that actually is on these cells. Right. And it's on those olfactory epithelial cells. So the concern is that, number one, it goes right to those cells in the back of your brain, in the back of your sinuses, preferably. So that could explain why they stop working and you stop smelling, right? But the other concern that we don't have any information really yet, but the concern of scientists is that the virus could get into the cells and track its way back up into the brain. We don't know that yet. And there's studies now. Remember, this is really early. And there's a gentleman named Jay Gottfried at Penn, who's one of our professors, who just got a grant this week from the National Institute of Health to study people who have early onset lack of smell. And he's trying to ask the question, if you have the lack of smell, is that seen more typically in people who go on to have really nothing happen to them? Or do those people develop either immediately or at some delayed point in time a more severe form of COVID? We do not know this yet, but it's under study. And so I hope that explains to you why this is kind of an interesting thing that's happening with the smell and taste.
Yeah, so it sounds like, there are a lot of questions here to figure out. One is, whether that loss of smell is an early indicator of other more severe symptoms, or whether it could maybe be just kind of that first stage, and that sometimes the disease kind of peters out and it doesn't develop further. The
most important thing is, and I hope nobody on this call ever contracts COVID or gets infected by the virus, but if you or somebody in your friends or your family, make sure they report whether that's happening, because it may actually become a very important detail. We just don't know that yet, but it might become a very important detail. It also, unexplained sudden loss of smell and taste should send you to the screening tent for sure. I would say for these months, go get screened with that, just with that alone.
Yeah, that's a really helpful bit of advice for everybody. So, we're all on the lookout for some of these symptoms. And even if you aren't necessarily developing a fever, this is something else to watch out for. Now, you mentioned that, this could potentially be an indicator of, more severe symptoms that develop later on. And we've talked a lot about how pneumonia can develop in the lungs, but we're now hearing about some of these more serious neurological conditions that affect the brain, whether it's from inflammation or stroke. Can you talk a little bit more about what we know about that so far?
Sure. So actually, initially, the brain wasn't really thought to be really relevant. We're hearing all about sore throats and sniffly noses and bad, coughs and pneumonia, and then subsequently a really bad reaction to the pneumonia that would put people on ventilators, for instance.
And actually, Frances, I'm going to interrupt you before we move on, because I think we have a question that I want to circle back to around the loss of smell before we move on to those. This is a really good question, is, when you lose those senses of smell and taste, do they come back?
Yes, they do come back. The vast majority of people, it returns. And the interesting thing is, in my experience talking to patients, is there some people that get it and have nothing else, and then it gets better. Then there's people that have the whole syndrome and kind of notice towards the end of their, cough and sore throats that they've lost their smell, and it's kind of the last stage. So again, we don't really know, but in the vast majority of cases that I'm aware of, at least, it reverses. It comes back over time. I mean, there's also a very long tail on the recovery of COVID, as you know. People get sick, and then they go through this sort of honeymoon phase and get a little bit worse, and then it takes them weeks sometimes to get rid of the muscle aches and the sense of fatigue. So just to point out to everybody, the most common symptom of COVID is about 90% of people have some sort of fever. Not everybody, but that's pretty common. About 50% of people have some sort of cough, okay? Somewhere between 10 to 70% of people, we don't really know, have this sense of smell problem. And headache, to now move into, happens in about 10 to 40% of people. So a little less than half of the people will have headache and muscle aches. And then things like GI complaints are pretty rare. But a third of people that really get some major set of symptoms will go on to this more severe form of like that pneumonia that I was talking about. And so, it's a real spectrum of like almost nothing to something that really can progress.
So getting back to that other end of the progression then.
Right. So talking about now what happens to the brain in all of this. So not everyone has, a brain problem. But as I said, headache can happen with a milder form and with a severe form, as can this anosmia. But other things that we have seen that, again, this is literature papers are just coming out even like last week and 2 weeks ago. It's all very new. But some of the things that we are seeing are problems with confusion, like seizures, epilepsy, not really epilepsy, but seizures can happen in these people. And people can have things like meningitis that you've heard of, like an inflammation of the covering of their brain, which they get a horrible headache and nausea. And it can happen with many viruses. So a lot of the things that COVID, SARS-CoV-2 does are not really different from other viruses that we have experience with. But we're seeing them now as part of this epidemic. So none of these are super unique. The anosmia seems to be, the lack of smell, it seems to be on the more unique side. But so things that can happen are the inflammation on the covering of your brain, which is like a meningitis, inflammation inside your brain, which is, we call it encephalitis. We're also seeing strokes happen in patients. So the strokes are interesting because what is a stroke? A stroke is when part of your brain has a lack of blood flow, or you can have a big bleed into your brain. So the word is used for both too much blood and not enough blood. So if you lose your blood flow because of a clogged artery, you're going to have a part of your brain that has no supply anymore of energy. And what will happen is whatever the function that part of that brain had is going to now not happen. Like if it was the left side of my brain, it's controlling the right side of my body. And if I had a stroke on my motor part, my hand would stop working on the other side. And that is how somebody would present. Or you have a visual symptom if your visual cortex, or you could stop speaking if your language area is gone. And a lot of the times when that happens, it's because a blood vessel that's supplying is blocked. And why do blood vessels get blocked? They get blocked because of blood clots and narrowing of the arteries. And typically in older people that have strokes, it's because their arteries are narrowed because they've got cholesterol plaques and scars in their blood vessels. So it finally closes down. But another mechanism, which is happening in COVID, is that the blood just becomes super clottable. And there's something about the virus, how it affects our blood vessel walls that stimulates blood to clot too easily in even a young person. So what happens is their blood just starts clotting all over the place. And if it clots in a vessel going to the brain, you get a stroke. Now, there have been some papers or some things written in the newspapers about there being a new group of young people getting strokes. Right. Actually, at Penn in Philadelphia, we haven't seen a lot of that, but it has been written out about. It can definitely happen. It can happen at any age, frankly. So we're aware of that now. Blood thinners are being used immediately on these patients. And in fact, people that are really, really, really sick with COVID now that end up on ventilators that haven't had a stroke yet, we're using blood thinners on them just in case their blood gets clotted to prevent those kind of strokes. So
but we don't really know yet why we're seeing this change in the properties of the blood because of the virus.
Well, we think it's, again, may have something to do with this ACE2 receptor expression, which is also on the blood vessel walls, that it's stimulating the blood vessel walls to send signals out to the blood cells to start clotting, among other reasons.
Right.
So that's kind of the story with the stroke part that many of you have probably heard about.
So one question that we've talked about before is the role of like the ACE2 inhibitors that are often taken by patients with cardiovascular disease. Is there a link here?
Actually, that's been looked at and it's all over the news and people are trying to figure that out. Right now, the indication is that it's not really interfering for good or bad. Right. It's not particularly protective to have an ACE inhibitor on you, and you could reason that it could actually hurt you to have an ACE inhibitor, but it's not showing at all. There's no studies that have shown that probably the doses we take, the response to the virus is so overwhelming that the doses we're taking for, standard blood pressure probably are not really playing into this as a factor. Again, but it's under study. So I can't give you a definitive answer on that.
But people should keep taking their medicines.
People should keep taking the medicines. And it's been shown that there's no added risk for, at this point in time. None of the studies looking at patient populations have suggested that people on them are doing worse than anybody else, or better for that matter.
Right. So getting back to the inflammation and the stroke, what are we studying to find out whether the virus is directly getting into the brain to cause those, or whether it's a kind of a downstream effect of the general immune response to the body? How do you distinguish between those two?
Yeah, I mean, you hit the nail on the head. These are very open questions still. I do not have an answer for that. That is exactly what research is trying to look at right now. How much is the virus actually getting into our brain tissue versus aggravating the covering of our brain or the blood vessels going to our brain, right? So it's thought that, that a lot of it doesn't require the virus to actually get into our brain cells to be causing these effects. Interestingly, some of the confusion that you see in people with that are further along with COVID isn't actually due to the virus sitting in their brain cells. It's due to the fact that their oxygen levels are so low, for instance, and their brain is just not getting enough oxygen. So then they get, a lot kind of really delirious and very slow and somewhat semi-comatose, in fact, from not having enough oxygen. And that's due to their lungs. The other is maybe some of you have heard of something called cytokine storm. And that means when your immune system just goes crazy and it just hits your whole body, and it can hit your brain too. So if you're being, what can happen sometimes is you have an initial infection and then your immune system revs up and the infection itself may start to be going down, but your immune system is so revved up, it starts attacking normal body parts. And in this case, parts of the brain.
Too much of a good thing.
Yes. And that we see that in a lot of other conditions that are, other viruses, also some cancer immune therapy, CAR T cell therapy, you can have a cytokine storm. So this has been well known, and it looks like that's happening in these patients. So again, we can take our knowledge from other areas and start treating those patients. So when we think that their brain confusion is from a cytokine storm affecting their brain, we can apply what we know, what we've used for other indications to help those patients as well. So,
Frances, we have a question that all of these symptoms that we're talking about now affecting the brain, are these observations of new symptoms just cropping up now, or are we just now getting a sense of the numbers to document these non-respiratory systems that have been there all along?
Absolutely. I think it's just, yeah, we're now getting the numbers and we're taking we're out of this sort of panic stage and people are really starting to sort through what this disease is and getting a lot more data, also as we do contact tracing and we start to understand clusters and can see people, know about people before they've even had their first symptom, we're going to learn a lot more of what this course looks like. And even if there are things that you could take early on to prevent later, worsening of the disease. Right now, we've just been slammed with people who are symptomatic showing up and we haven't been able to screen them. And as we start to screen, we'll get better at kind of defining this disease. This is a worldwide effort. This is something that every major university, I know my university at Penn, every university in Philadelphia, every university in the country is actively engaged in some sort of either consortium study or actually coming up with their own interesting, specific study. So I think people have to realize that there's a massive effort. And just to say that I'm sure everybody's aware of the fact that when we're all in shelter in place, hospitals have really backed down and now they're starting to creep back with a little bit of like the non-essential surgery and visits, but most people have been told to stay away as they are told to stay away from everything, right? And just go out for essential. So we are where no research is happening in our universities for the very same reason. So all like my lab that I used to do work on epilepsy and things, we had to shut it all down with respect to these rules of social distancing and isolation and not putting people at risk as they navigate their way to work or back, or amongst at the workplace. So now, interestingly though, the only research that has been allowed to go on and is being actually growing almost everywhere is COVID-related research. So, you might drive by a university research institute and say, wait a minute, I thought they were being safe and, nobody should be in there. And you see people going in, it's all COVID research right now. Yeah. So basically all the research the only research that's being permitted in our universities, with bar some very, very special exceptions, is COVID research. And it's going, NIH, National Institute of Health, has given lots of new money. They're making it so easy for people to get money really fast to get to the crux of these matters. So I think we're going to see what normally might have taken 5 to 10 years to learn happen within a year because of the acceleration of effort on so many people.
It's really remarkable. A question to circle back. Somebody asked before about the sense of smell, but I wanted to save it because I think it actually applies to everything that we've talked about so far. Is what do we know, if anything, about the long-term consequences about some of these symptoms, whether it's a sense of smell, whether it's the effect of stroke?
Yeah, we do worry about that. And it hasn't shown up yet too much in the Chinese. And remember, we only have 5 months of
it's hard to believe, right?
With identified patients, right?
Yeah.
And that's if you caught like the very first couple of weeks of patients and you were able to follow them through. And that means that they're all in China. So, there are things that are happening that we see that are already we know about that are typically happen in other viral diseases after the virus is over. And there's something called Guillain-Barré syndrome, which is somebody can have a viral syndrome, any kind of viral syndrome, and then suddenly begin to get weaker and weaker and weaker and really almost paralyzed. And it's an immune attack left over from the virus that decides to pivot around and attack you and your nerves. And people get really sick and have to be sometimes ventilated because they can't breathe. And that we see in a lot of viral syndromes. And it's one of these autoimmune, we call it autoimmune diseases.
Auto meaning self.
Happening. Yes. And it takes weeks to get better from that. And we can give therapies that directly try to suppress, your own immune response, your own autoimmune response. We see the same thing happening in COVID patients. So that gives us a hint that it's not all about these first couple of weeks where you actually are infected with the virus, that there are these after effects, if you will. So that's one. And that
happens after you feel like you've recovered. And then it
happens after you, if with other viruses, people can have the flu or, bad cold or some random virus. And they think they're better. And then suddenly a week or two later, these strange symptoms happen. It's very, very rare, very, very rare. And we have treatments for it, but we're starting to see that with COVID. So that's about the only one of these sort of post-infectious things we see so far. What we do worry about is that, remember the Spanish flu, where actually it hit Philadelphia pretty hard, right? Back in 1918. And when that flu was over, within months to years afterwards, people who had been infected, especially when they got older, would suddenly develop Parkinson's disease, something that looked like Parkinson's disease. And it became known that it was associated with a history of that encephalitis that they'd had back when they were infected with that flu. And all those people have passed, because that's, they're not alive anymore, because they would have been, probably 100 about 20 years ago. But we don't know. So we're going to follow these patients. I would say that today, our ability to diagnose and treat that kind of disease is so much superior. And we will be able to, people are in fact looking to see, do the parts of your brain, it's called the basal ganglia, that go abnormal, with the degenerating Parkinson's disease, are they being affected by this virus when you scan the patient? Do you see more inflammation there? And people are being followed for that. We haven't seen it, but just to give you an idea, everybody's on the lookout for exactly that, to be careful.
So I wanted to switch gears for the last part of our conversation, Frances, because we've talked a lot about these neurological, symptoms that affect our physical health. But there's been a lot of conversation about the mental health aspects of this crisis as well. We can talk about the mental health impacts on patients and caregivers, as well as, kind of the rest of us that, haven't necessarily been directly impacted yet, but are still, struggling with the environment that we're living in. What advice can you give us?
Yeah, so there's a great deal of concern around people's levels of anxiety, which are clearly going up. People who have pre-existing mental illnesses being made worse by these periods of social isolation and just general stress. We see that, we're all aware that we're seeing some people get a little more agitated and sort of acting out a bit and gravitating towards conflict because of this sort of baseline of this unknown, this ambiguity, like, free-floating anxiety, if you will. So in the near term, psychiatrists are on the lookout for those kind of things. Increased anxiety that's tipping somebody over the edge, somebody who already has depression or bipolar disease or some other mental illness that is being pushed to their limit. And also, are they getting their meds? If they already have a diagnosed medication, a diagnosed, psychiatric illness and are doing great on medication, has social isolation or the quarantine or the, stay-at-home orders made it difficult for them to get their medication? They must continue to take their medication. So that's a big deal because everybody's somewhat on edge, with this.
Sure.
There haven't been the studies yet done. I think the psychiatry is so complex, and we're waiting to see some studies now come out. But certainly at hand, we're seeing instances of agitation and increased depression. And then the next concern, so the concern is, can people access their mental health, caregivers? And a lot of new mental health apps are out there. I know with the CARES Act, mental health is covered when it's related to COVID. So people should take advantage of resources and seek those through their primary caregiver initially, and get to those fast when they feel that something is not quite right. There's also, so there's needing to address those issues quickly, finding time to go online and look at apps that might help you think about how you meditate, how do you recenter yourself. People are saying a lot about, don't keep turning the news on. If it's a stimulus that makes you upset, limit your time with like the outside news, the stressful stimulus over each day. Find a thing that you love to do each day. Find one or two little small pleasures, which we're all rediscovering because we're all stuck at home. Yes. But trying to find these little positive points in the day. The other part where we are worried about is the PTSD, post-traumatic stress disorder. So right now, this has all the hallmarks of a war, all the classic phenomena that you think you see when there's a war or a 9/11, these like a stressful hit to your life line. And what is that going to do? And where the psychiatric, community is very much aware of this and feels that by addressing your mental health, like in the near term, creating, making sure you're not excessively socially isolated, doing some of the things I just mentioned before, will reduce your risk for post-traumatic stress disorder. But PTSD, obviously we have a higher risk for it right now. And then that can affect you later down the line where suddenly all's going well and some trigger comes in and you start to be unable to cope in an otherwise normal situation because you've been triggered by something that happened to you before. And that's a phenomenon that we know is post-traumatic stress disorder.
Right. So we do have a lot to keep our eyes on, as in the months and years, following this immediate part. And yet there's something about it being a shared experience too, that that it's something that we're all going through together. Where can we draw some hope out of that?
Well, I think it's known. I mean, I'm a neurologist, not a psychiatrist, but I do know that there's literature to state that, if you compare even World War II veterans to Vietnam veterans, or even the Gulf War veterans, the latter two didn't do as well as the World War II veterans because it was such a common experience. And the problem is that, like, the Gulf War veterans were, plucked out of an otherwise perfectly happy society, go and experience horrendous things, come back, and they can't cope with walking around a grocery store. They can't live their old life anymore. So, because it's so different from everybody else, they hold things that no one can relate to. So, yes, we all are relating to this, but we're still, vulnerable to suffering from it. Yeah. Nevertheless, talking things out, being a community. It is amazing to have the internet, be in our midst and part of our lives to the extent it is, when you think about how we are all becoming, adopting, new ways of interacting with each other over virtual, media. I think people are getting really creative, and I think that's obviously very healthy. But it's still, you need still to address your levels of anxiety. And I would say that the other part is this sort of slowing down of life that I hear a lot of people. This is not through any medical. It's just personal anecdotes that, I'm hearing a lot of people say, they're obviously very stressed, but boy, they're enjoying, stopping and smelling the roses, literally, and just having everything slow down. That could be good, but it can also be bad, because things that would have taken us, X amount of time are now taking 3 times as amount of time. Like, just think of going to the grocery store, the steps involved now, and the cleaning, everything. And, so there are these added frustrations with that slowdown in life, but I think we have to take from it as much positive as we can. And, like Ben Franklin said, out of adversity comes opportunity. And I think we have to, stand with that and think about, like, while we would never have wished this to happen on anyone, there are amazing things going on. And frankly, in medicine, one of the things that I'm sure I hope nobody's had to contact their physicians, but if you had a chronic disease and you had to contact your physician, you'll notice that you're being offered telemedicine visits and video, like we're talking right now with the doctor. And it's extraordinarily convenient. And while you can't get everything accomplished, you can get a lot accomplished. And in certain, certain areas, others, you're not going to get surgery over the internet, but, but there are certain things that you can touch base, and it's reassuring to the patient. It prevents something from progressing. And that's the other piece that we are very worried about in medicine. And this goes for neurological, psychiatric, and any medical problem, is that people are so scared about coming in or coming out of their houses in general, that they're holding back on getting care. And we are very worried about that as a medical profession, because we're worried about all those mammograms and colonoscopies, all those, routine screenings that had to happen, or the check of somebody with rheumatoid arthritis or diabetes or heart disease that needs to happen. These are not happening. And so to the extent we can use telemedicine to just get to the patient is wonderful. And it's good because the CMS, the Medicare, Medicaid has agreed to pay for those. So, it's open, and cover it if it's COVID related. So I think it's, I don't think telemedicine is going to go away. I think it's going to be here for a while. And I think the other issue that's happening in hospitals, just for people to know, is that even when we do reopen, we're not going to be able to reopen, just like a restaurant can't, to the same extent that we did before. So our waiting rooms, a waiting room that might have held 25 people, can now only hold 8, and because they've got to all be spaced. That means the day is slowed down by that much. And so we're going to still be using telemedicine, I think, to fill in the gaps where people won't be able to come in.
So I think that's a good example that speaks to another question that somebody's asked. Is there hope that this present event will result in us being better prepared for future events? So I mean, that's a very broad question. I think, telemedicine is one example where we can see how learning from the infrastructure that we're putting in place now could help, deal with, a future. But what else do you see?
I see that we hope that on the health side, that public health, it gets another closer look now, that we think about, our storage, what are our stores of things like ventilators and these essential materials, and how, we learned how not accessible they were and that they weren't adequate. And I think this has been a massive wake-up call. I think most people in infectious disease would say, if this happened once, it can happen again. And with all of our global travel only increasing, it is going to spread as fast as it did this time, if not faster. So we have to be ready next time. And I think it's going to definitely provoke, the federal and state, relationships, ironing out, like, what is a public health initiative, and where does that responsibility fall? We're seeing it be very, lumpy right now. But we're learning, we're all learning. And I think, I also think that it's really pushed research in this direction to become very advanced. And I'm pretty excited about that, because I think we're going to be way better off if we ever had to address this again. Look at the vaccine development progress right now. There isn't a vaccine yet, but the number of laboratories that are busily working for it, and we all believe that there's going to be a drug that in the meantime will, you can see a little bit of that being discussed with some of the antivirals now in the news. But we believe that even if a vaccine isn't available in the near future, we'll probably have drugs that diminish the severity and certainly decrease the mortality rates of this. So, but
we have to actually remember to apply those lessons that we're learning. Right. So that's on all of us. Well, Frances, thank you so much for joining us today. I know this is an aspect of the disease that we hadn't talked about before, so we really appreciate your expertise in helping us understand these.
Well, thank you. And I hope people have learned a bit about neuroscience, as well as how, SARS-CoV-2, affects the nervous system and our brains and our mental health. So please all stay well and take care of yourselves. And please follow the stay-at-home rules that are present in wherever you live.
Great advice. Wash your hands.
And wash your hands. Socially distance.
Thanks to everybody who joined us today. We'll be back at 3 o'clock next Monday. So we hope you'll join us again for another conversation. Thanks, everybody, and stay safe. Bye-bye.